We have Mr. McGregor next for 5 minutes.
Thank you very much, Madam Co-Chair. Dr. Gain, I'd like to direct my questions to you. There's been much has been made of the fact that someone who has an incurable mental disorder will have to show an extensive treatment history in order to access MAID for MDS-UMC. We've got the federal government's expert panel, we've got Health Canada's MAID Practice Standards Group, and CAMAP. But, the expert panel did say that no further legislative safeguards are required. And if you read the criminal code, there is a requirement that a person has to be informed of the means available. What are your thoughts on that? Because you've previously voiced some discomfort with that. Like, why are these standards not enough compared to an actual legislative safeguard within the criminal code?
So a few things. One is, keep in mind that I know of no other thing we do in medicine that requires a carve-out from the criminal code to avoid prosecution for homicide. What we're talking about is helping people die when they're not dying. That's the bottom line of what we're talking about. And so then in terms of the potentially required safeguards, to answer your question, when they're not in legislation, the consequences are, let's put it this way, there's a lot of leeway that assessors are given. And this is not just coming from me. This is coming from people working in the field. Dr. Lee, who was the lead for the CAMAP guidelines, she has specifically said this, that the current law permits too much latitude based on practitioners' personal values. Currently, it is a legal fiction that determinations of the eligibility of MAID are based on objective clinical judgments. In fact, I regularly witness practitioners' values influencing the interpretation of the current MAID eligibility criteria and safeguards. And if you recall, when Dr. Gupta testified here, I found this quite remarkable. She seemed to use as a measure of things going all right and that we shouldn't worry, the fact that no assessor has been prosecuted. I mean, that's not the sort of threshold that I go by. And if people aren't aware of this, CAMAP guidelines, this is not in the mental illness piece. This was in a prior thing from 2022, which they called Interpretation and Role of Reasonably Foreseeable. They quite literally go through a process of providing guidance for assessors to convert Track 2 MAID requests to Track 1, and for proceeding with Track 1 MAID, thereby bypassing all Track 2 safeguards, including the 90-day period, even if assessors don't agree the patient should be on Track 1.
Thank you. Thank you for that, Dr. Gain. We've also heard, in my opinion, there's been conflicting reports on the figures with regard to the number of psychiatrists in Canada who are comfortable with this going forward versus those who are not. I think, you have previously referenced the Ontario Medical Association, psychiatrists in Manitoba. Do you have anything to report to the committee on the numbers that you are aware of? And furthermore, how could this committee get its hands on actual surveys from psychiatrists, from organizations like the Ontario Medical Association, from Manitoba, so that we can actually have definitive numbers, and like, should we be sending for those documents to have them tabled as a part of this report?
So I can't speak for Manitoba, but for Ontario, I'm happy to forward those to the committee afterwards. You can see exactly the questions that were asked and how they were answered. And the results of those are consistent with the vast majority of surveys that have been done of psychiatrists. They show that, yes, yeah. It's about 2 to... So firstly, most psychiatrists are not conscientious objectors. Like me, they support MAID. I'm not a conscientious objector. 80-85% support MAID. But by a 2-to-1 ratio, 2 to 1, they do not support MAID for sole mental illness. These are not the people who are the most stigmatizing and discriminatory. They've devoted their lives to working with people with mental illness. Happy to forward you those numbers afterwards.
And finally, just a quick comment from you. I mean, much has been said that we don't need to have consensus on this, but what does it say to you when such a high number seem to be opposed with those kind of ratios?
Very briefly.
What it says to me is that not only has this not been driven by consensus, this is a small minority with ideological viewpoints that are true believers that have driven the expansion.
Thank you. At this point, we'll transition to questions from the senators. Senator Osler, you have 3 minutes.
Thank you, Madam Chair. And for something different, I have a question for Dr. Gittins and Dr. McHale. In August 2022, the Canadian Psychological Association responded with a series of recommendations to the final report of the expert panel on MAID and mental illness. And the recommendations included a statement that, quote, psychologists must be included. Question number 1 is, outside of government-operated mental health services, are psychologists covered under any provincial or territorial health insurance plan?
So psychologists are not currently covered under a health insurance plan. In fact, I think it's important to note that in this discussion, when we're talking about MAID, when mental disorder is the sole underlying medical condition, we're really asking to examine mental illness in the same way we look at physical illness. And as a country, we have not yet established parity. So care and treatment of mental illness is not covered by Medicare, nor is it readily accessible.
Thank you. And then a second question. In this context, where currently many patients do pay for psychology services out of pocket, how would the involvement of psychologists assist in this country's state of preparedness and readiness?
Yeah, I think that's a critical concern. Obviously, to do a thorough assessment is not a short process. It's a fairly detailed process, and that can be expensive for someone who is looking to have a psychological assessment for determination of eligibility. Unless it occurs within a hospital setting or through Veterans Affairs, I think most people would not be able to, or a large majority of people wouldn't be able to proceed.
Thanks, Madam Chair. And I will cede the rest of my time back to the committee.
Thank you. Senator Kucher, you have 3 minutes.
Thank you very much, Madam Chair. Dr. Gain, I'll ask you a couple of questions. Most of them only require yes or no answers, so if you pontificate, I'll regretfully cut you off because we have only 3 minutes. First question is, are the medical regulators of each province responsible for the oversight of medical practice in their jurisdiction?
I guess so.
Yeah, that would be a yes.
Sorry, it took too
So
much.
following, we've heard from Dr. Grant, who is the chair of FEMRAC, that they are ready. I also have received some correspondence from people who have some responsibility for MAID readiness in their own provinces. Dr. Hayden Rubinson of Alberta says, Alberta and other Canadian jurisdictions are ready for the sunset clause banning MAID where the mental disorder is the sole underlying medical condition to lapse. Dr. Celine Etches of Nova Scotia, despite the challenges that the legislation, et cetera, we feel well prepared in Nova Scotia. Dr. Lillian Thorpe in Saskatchewan, I believe we can make the expansion to include MAID, MD-SUMC safe and appropriate. We are ready. So it's interesting because those people who are actually responsible for doing this work say that they have readiness. Now, can you help this committee understand, are there bodies in Canada that accredit medical training programs?
Well, as you know, Senator Kucher, there are.
Yes, and but maybe the committee may not know. What are those 2 bodies that accredit medical training programs?
I'm happy to answer your questions, but it sounds to me like you actually know the answers you want.
I'm asking
And
you.
Yeah, no,
Are you
I
gonna-
understand that. But
Yeah, so what are they?
It's the Royal College and the CFPC.
And that's the Canadian College of Family Physicians of Canada. Are you aware that they have accredited the CAMAP curriculum?
I'm aware that 100 people seem to have registered for the CAMAP curriculum.
No, I'm
That
asking you
doesn't
if you're
mean-
aware that they have accredited the CAMAP program.
I'm not aware of that, and it doesn't mean anything to
Okay,
me.
so it doesn't mean anything.
No.
So I think that helps us understand your testimony better. Let's let the record show that those bodies which are responsible for accrediting medical training programs, the Royal College and the College of Family Physicians of Canada, have accredited the program. They are responsible for making sure that these training programs meet expected standard. So are you telling us that your opinion of the program overrides the accreditation process of both the Royal College and the College of Family Physicians?
I'm telling you that those are not based on evidence. It's not my opinion.
So
They're
it's
not
your
based on any
opinion that,
evidence.
that these colleges that accredit our medical training in this country should listen to you? Did
No,
you
I'm not
actually take the
personalizing it.
training
As I said,
program?
evidence.
Did you actually take the training program, or did you only read the module?
I did not want the number of my download to be co-opted as a sign
No,
of
no, no.
readiness.
Did
as
you
happened
take?
in the
I didn't
previous
ask that.
committee.
I asked, did you
I read
actually
the
take the
module,
training
and
program?
I read the module.
Thank you,
You read the
Senator
module.
Kucher.
We just need to finish this because the module is
No.
not the training
No,
program.
we've had more generous with the time than the 3 minutes, so
Okay,
we need to
thank
move
you
on.
very much,
Thank you.
Chair.
Senator Martin, 3 minutes.
Yes, thank you. My question's for Dr. Gand. You mentioned in your testimony about the European data and the gender gap that was emerging. Do you think it's important for Health Canada to collect data on the socioeconomic conditions that people who are administered MAID live through?
Yes, I do. I was quite disappointed that the data that would be valuable was not actually provided in the last report that came out for the 2022 data. And despite that, there are signals in there that suggest signs of trouble for the expansion that's happening. I'm happy to elaborate on those if you like.
Yes, would you elaborate?
Absolutely. So the data collection right now to pick out marginalization, because this is what we're talking about. You know, the idea that many people still get it for cancer and other things, that's true. But we're expanding it to allow other people to get it for all sorts of other reasons. And if we ignore that marginalized can seek it for different reasons than the privileged, that's a problem. So we're not collecting the data properly except yet, or at least it's not being reported. What we have seen is some increases in striking things. So the largest area of increase, I believe, was the other category. That went up to 15%. 15% of 13,000 deaths, I'll remind you. And it is now the third most reported category. And in that, there's a gender gap. 17% women to 12.8% men. The other category also includes frailty. And you see a similar gender gap in more women getting made for multiple comorbidities like arthritis and hearing loss. 12% versus about 8.3% for males. And in all of this, about 1/3 of people get it citing feeling a burden on their family. And there's even more of a gender gap if you then break it down to the non-reasonably foreseeable death track 2 numbers. There, the gender gaps go to up to 60% higher for females than males.
You have about 1 minute.
Okay, well, 13,000 is a very astounding number to me. I was talking to an official from a country comparable to Canada that their numbers are in the hundreds. So I'm actually just shocked by the numbers themselves. So you're saying that Health Canada should be reporting in greater detail the quality of, the nature of, and the adequacy of services people receive before they access MAID.
Briefly, please.
Supposed to after Bill C-7. I actually thought that that's why the report for 2022 was delayed by several months. It came out a few days after the vote on Bill 314, and it did not have any different reporting data compared to the prior reports.
Thank you. Yes, so we're going to go into the second round of questions. So we have for Mr. Cooper for 3 minutes.
My questions will be to Dr. Gained. Dr. Gained, Health Canada came out with recent data on MAID for 2022. Do you have any comments or observations on that data, and more specifically, anything that may be relevant to the question of expanding MAID for mental illness?
I do, and actually I started to allude to that in the prior answer as well, some of the gender differentials, the gender gap that's emerging in some areas of MAID, including Track 2 and the other areas that I spoke about. You know, obviously the headline numbers being 4.1% of all Canadian deaths, I have to say that the way Health Canada has reported on that surprises me. It seems rather blasé. They say that it's a steady rate of increase of 30% every year. That's not the math that I went to in school about whether that's, something that maybe should raise eyebrows. No other country in the world has had that sort of increase in their first 6 years, 7 years of implementing MAID policies. I don't know what it means, but it is significant. The other thing which is concerning to me is we honestly don't know how many people truly were track 1. You know, when I read the CAMAP guidelines that essentially say that you can be, a person may meet the reasonably foreseeable criteria if they have demonstrated a clear and serious intent to take steps to make their natural death happen soon or to cause their death to be predictable. Examples might include stated declarations to refuse antibiotic treatment of current or future serious infections or to voluntarily cease eating and drinking. I had heard anecdotally of some people being converted, so to speak, from track 2 to track 1. In their guidelines, they actually say you can do that. So I don't even know how many truly were track 2 versus track 1. And if you also look at the numbers of the refusals, the rejection numbers of MAID, it's remarkably low. So there are troubling signs in the numbers.
It has been asserted by Dr. Gupta as well as other activists like Jocelyn Downey that excluding persons suffering solely from an underlying mental health disorder constitutes a paternalistic assumption that such individuals are unable to make autonomous decisions. I'd be interested in your comments on.
Very briefly, Dr. Gain.
I disagree with that. It's something where we have a piece in impactethics.ca today. It addresses that even when somebody is able to make a fully autonomous choice, if the assessor thinks they can do something that they can't, that's the problem. It's not about the autonomous choice of the patient. It's about the assessor pretending that they're doing an assessment that they
Thank
can't.
you very much, Dr. Gain. We have Mr. Maloney. You have 3 minutes.
Actually, Mr. Scarpelletti is going to take the time.
Okay.
Oh, thank you, Mr. Maloney. Very gracious of you. When you're in this part of the batting order, if I may say, all your questions have been asked, but I'll take nonetheless. I'll revisit some things. So, you said. Dr. Gain, that the training programs are not based on evidence?
That's correct.
Could you elaborate on that?
I can. So especially at the 2 key issues that are problematic for MAID for sole mental illness, the issue of how you predict irremediability, meaning that the person's condition will not get better, and also how you supposedly separate suicidality that benefits from suicide prevention from motivations for people seeking MAID for psychiatric conditions. And there's nothing in there, especially on the latter, that actually talks about how to do that other than saying you need to make the distinction. They talk about suicidality refers to the thoughts, plans, or actions to end one's life. They talk about a few other characteristics. Almost all of those also apply to somebody who is asking to end their life through MAID for a psychiatric condition.
And you said, or I understood that you said this idea that, because all along I've been operating under the assumption anyway, I don't know about the other committee members, but all along I've had this idea, I believe this idea that one would only be eligible after looking over, let's take a number, 15, 20-year span of treatment that did not bear fruit. But you're saying this is not in the law, of course, and it's. Did you say it wasn't in the module as well? Is it?
So in the guideline, or in the guidance, I would say, in the guidance that they give, it is true that
this is the Health Canada guidance, or
so actually it would also be even from the expert panel report. They do talk about you should weigh the lengths of treatment, but they don't actually say how many treatments, the lengths or types you should have, which is very different from any other guidance we have, even on issues that don't lead to death. When we're going through what's the next step of somebody who has treatment-resistant depression, for example, we actually have guidance on the sort of paths we should take. Here it is left completely up to the assessor, and that's the problem, because there's no legislative safeguards there. And some assessors may well be very dedicated and comprehensive. Others will not be. I can tell you just very briefly that I was speaking with a colleague yesterday
Seconds.
about a patient who got MAID while they went on a pass from psychiatric hospitalization, and the psychiatric team had not
Thank
even
you.
known.
Thank you very much. Monsieur Thériault, you have 2 minutes.
2 minutes.
2 minutes? Okay. You said earlier that in 25 years of clinical practice, there's been only a small number of patients that you were unable to cure. Does that not prove, contrary to what you said earlier, that we're not facing a huge number of potential cases, but a small number of individuals that might have access to MAID? And were they to have access to MAID, what would be the conditions under which they'd have access to it?
So I'm going to actually answer your question from someone who's done a data analysis on this. He's an internationally renowned researcher on MAID and suicide numbers, and he estimates that as a lowball estimate, it'll be 1,250 to 2,500 cases per year, but it actually would be higher. The basis of that is that about 5 to 10% of requests for MAID are granted in the Netherlands. And when you translate all of that, it suggests that in Canada, we would end up having between 2,500 to 5,000 requests. And the rules in Canada are...
But we already do know that, sir. I asked you a specific question.
I misunderstood. I thought you asked me, wouldn't it be a small number of cases? And I said, no, it wouldn't be. Did I misunderstand the question?
Well, I said that in your clinical practice, you've indicated that over the course of 25 years, there were only a small number of patients that did not benefit from your care. So I'm saying that, contrary to what you're claiming, only a small number of patients would be asking for MAID among your patients. Based on your criteria, would have they been eligible for MAID, in your opinion? Or is it that there'll never be sufficient conditions to warrant someone getting MAID?
Yes.
Monsieur Thériault, I don't have a time machine.
Okay.
So I could not go back in time and predict in advance. And if I had, many more would have actually thought they'd never get better.
We will, the last questioner, Mr. McGregor, for 2 minutes.
Thank you, Madam Co-Chair. Dr. Gain, I'll ask you a question I asked one of the witnesses in the first hour's panel. And that's just that, I've been on this committee from the beginning, and what I've personally struggled with is, recognizing the fact that, individuals have rights, they have agency, they have capacity, those are constitutionally protected rights, but that we also, as a society, have a duty to protect the most vulnerable. And I guess, I'm indirectly alluding to the constitutional arguments about this, the fact that, yes, we do have rights and freedoms, but those rights and freedoms can be subject to a Section 1 analysis, which can place reasonable limits on them. I guess my question to you is, as a physician, a psychiatrist, and with your years of experience and on this specific subject, how have you personally approached that, trying to reconcile rights of individuals with their agency, their capacity, their ability to make decisions for their own body versus, our collective rights to defend the most vulnerable?
Excellent question. It gets to the heart of a lot of this. And I can tell you that at the beginning, I used to end my talks with a precariously balanced kind of picture that suggested, we're going to find one bright balance point, a solid line, that things are right on this side and incorrect on that side. I no longer do that because I don't think we can find a balance point. It's the issue of over-inclusion or under-inclusion. And to me, the question becomes, which mistakes do we want to make? And I think offering and providing death under false pretenses is a pretty big mistake. The other point I'll make is that when we expand to sole mental illness and we're offering death under the false pretense of saying your medical condition won't improve, and more than half the time we would be wrong in that, and we think we can separate suicidality, These are also people who are more marginalized through psychosocial suffering, which we also know fuels MAID requests as you get further and further away from reasonably foreseeable death. You know, people shift to
Thank you,
try to
Dr.
escape a
Kane.
life of suffering, and that's challenging.
Okay, with that, I'd like to thank all of our witnesses for your testimony this evening, for answering all our questions. We have reached the end of this